My name is Lily. I'm the office manager at Community Health Resource Center. Thank you for joining today's presentation, Understanding Lung Cancer, Raising Awareness for Early Detection and Prevention. Today, we're fortunate to have Dr. Heba Ismail and Dr. Wang here to present for us. Dr. Ismail is board certified in critical care medicine, internal medicine, pulmonary disease, and pulmonary intervention, and specializes in the evaluation and diagnosis of pulmonary nodules and masses. And Dr. Wang is board eligible in hematology and medical oncology. Before we get started, I'd like to share a little bit about our organization for those who haven't joined our programs in the past. Community Health Resource Center is a nonprofit organization here in San Francisco. We were established nearly 40 years ago by doctors at California Pacific Medical Center to provide resources and care that would supplement their work with patients to support their overall health and well-being. Today, we provide 4 main service areas. Those are social work or behavioral health services, nutrition counseling, community health screenings, and community health education events. And just as a reminder, the information provided in today's presentation is for educational purposes only and is not a substitute for professional medical advice. And with that, I'll go ahead and pass it along to Dr. Wang to introduce herself and dive into the presentation.
Well, thank you so much, Lily, and thank you for organizing this event and making lung cancer screening and very visible. And hi, everyone. My name is Wang. I'm a medical oncology and hematology doctor here at CPMC. I actually got training. I had my 6-year medicine and hematology oncology training also at CPMC. So being in the system and being in San Francisco, I would say this is my 7th year. So it's great to see everyone here. So there might could be the delay. Okay, so the main focus or topic of the today. Oh, by the way, the reason we're doing this in November because November is our Lung Cancer Awareness Month, and we have our ribbon color as a pair or white. We probably don't see this ribbon too much. We see breast cancer ribbon a lot, which is the pink color, but we have our ribbon as well. And November is our Lung Cancer Awareness Month. Okay, so in light of that, the topic today is really talking about some facts of lung cancer screening, who are the people or patients needs to be screened, how do we screen it, and why we screen it. But the general kind of slogan or one take-home message is early detection of lung cancer saves lives. Some facts about lung cancer. So lung cancer is actually the most common cancer type worldwide. In US, in China, in Europe countries, globally, it's one of the most common and deadly cancer types. Roughly, lung cancer can be divided into 2 major subtypes. If you look at the bottom of the pie chart here, you see multiple little kind of pie. But the non-small cell lung cancer being the major subtype of the lung cancer, and 15% of lung cancer are small cell lung cancer. That's just like the rough subtypes of lung cancer. 70% of patients, when they're diagnosed with lung cancer, they're diagnosed with at an advanced stage. And that is because when lung cancers start to appear in one's lung, they rarely give out symptoms. Again, leading cause of cancer deaths globally, but more into details. And if you look at the kind of the graph to the right, those are the common types of cancer. And you can see the top, which is 36.9% of all cancer-related deaths. Lung cancer is more than 1/3 of them. It's roughly 1.8 million deaths annually, and then 5-year survival rate for lung cancer is only 28%. I briefly talked about this already, so we're going to skip this. Again, some numbers, why screening is important. Early stage lung cancer often don't have symptoms. When you have hemophysis, when you have chest pain, when you have significant breathing trouble, and that's usually indicative lung cancer has probably occupied a big space in your lung or invaded the vessels and causing the bleeding episode. Early stage lung cancer, they're often asymptomatic, and if we don't do screening tests, we will not be able to find it. So around 70% of lung cancer cases are detected at late stage without a screening. With screening, though, which is kind of good to put those two numbers together or statement together, is with screening, 70% of lung cancer detected at early stage. And as you can imagine, intuitively, early stage cancer are just easier to manage and easier to get rid of, has better survival rates. And this is looking at the details of lung cancer survival rate depends on the staging or whether the cancer are localized, regional, or distant. And if you look at the table on the top, which is marked in red, localized cancer, which is 70% if we do screening, and their 5-year survival rate is 65%. And you say, why was this still not 100%? But if you compare to the bottom of the line on this table, which is distant lung cancer has migrated or metastasized to different parts of the body, the 5-year survival rate is only 9%. And the caveat of this data, this is a sealed SEER data. It's a very comprehensive oncology kind of database. This is combined data from 2012 to 2018. Of course, I think in each staging, I think those numbers might be better these days, and we're all going to be looking forward to the data. So the early stage, the better survival rate. So how do we screening lung cancer? In our program, low-dose CT is a standard actually across in the guidelines. Low-dose CT is what's recommended. There are many trials that compare different modalities. Maybe we'll talk in the morning next slide, but currently low-dose CT. So the left side is a CT scanner for people who hadn't taken a CT before, because I haven't personally taken a CT yet, so I always wonder what it looked like. So open channel scanner, and on the right side, so they're taking slices of your lung or your chest, and then they will then compile those slices together and then make a 3D picture of your lung tissue. And on the right side, you can see a CT, a scan, a slice of the scan, and they can really pinpoint the tiny nodulars or lesions in the lung. For example, as this arrow was pointing at, there is a tiny vague lesion on the right side of the lung. So those are low-dose CT, what low-dose CT scan can do. So as I was saying, that low-dose CT scan, historically it was chest X-ray, and even historically sputum cytology. Those are the modalities for lung cancer detection. And soon we find that low-dose CT is the best. And here are the advantages of it. And compared to regular CT, it really doesn't expose people to high radiation dose. It's 90% less compared to regular CT scan. That's one. People say it's very comparable to a mammogram that's done for women for breast cancer screening. But despite low radiation doses, it does provide a lot of details compared to chest X-ray, as that scan was showing in an earlier slide. So it's better than X-ray. And because it's more details, it can lead to more accurate diagnosis. So lower rate of false positive or negative. And it's much faster in regular CT. So this is the standard modality and for lung cancer screening, low-dose CT. Who should get screened? In general term, will be whoever is higher risk for lung cancer. Smoker, current smoker, former smokers aged 50 to 80, anyone who had 20 pack year smoking history. So meaning that you've smoked 1 pack a day, smoked 20 years, or you smoke 2 pack a day, you smoked 10 years, something. So your number of pack per day, multiple the years. And if that's over 20, that will be indicative of screening, because we consider that high risk. And that's just around smoking. Other factors, right? There are definitely other factors what put one in a higher risk for lung cancer. And those are, for example, family history of lung cancer, even though hereditary lung cancer is rare, but doesn't mean that it's completely none. So those are one factors. Other kind of lung cancer risk, because, for example, exposures to asbestos, exposure to silica, dusts, air pollutions, those are known risk factors as well. So persistent exposure or long-term exposure to those non-lung cancer risks are also considered high risk for lung cancer and should be screened as well. Boiling down, everything needs to have having a mortality benefit, meaning survival benefit for things we do, especially, in US healthcare system. We need to prove that it does benefit people. This is one of the trials. This is, I believe this is the Nelson trial data, and compare people who've gone through screening. They enroll patients, and then they randomized into either screening or no screening with low dose CT in Nelson trial, and then they look at the survival or the rate of death. And what we can see is about 24% of relative reduction in lung cancer specific mortality. So about a quarter less likely to die from lung cancer from Nelson trial. The data quoted here from 20 to 24% is a compile of different clinical trials together. The benefit they've seen is ranging from 20 to 24%. Depends on how the study was designed and how many years was screened and all the nuances. But generally, there is a survival benefit that is about 20 to 24%. And that is the key reason, the fundamental reason why lung cancer screening is needed and needs to be implemented in the healthcare system. There are concerns for one to receive CT scans yearly base. They worry about radiation, which we already mentioned, it's low dose. They're also worried about unnecessary procedures to be done, which is what we call false positive. So there is a kind of misconception that there's a very high false positive rate in those trials I mentioned for when they're trying to see if lung cancer screening is helpful. But then in reality, in real cases, if you really count the full positive rate, which is by definition is a positive low dose scan, if your doctor call you say, hey, your CT scan is abnormal by this on this year, it does not mean that you have a lung cancer, and that shouldn't be considered full positive. So it depends how we define things. I think there are some misconceptions to clarify here. And in our center, because we do see a lot of patients who are going through the screening, we are able to tell the nuances of how those nodules look like on the CT scans and the size of it. And we often follow those abnormal CT scans to with their kinetic of those lesions, and how do they disappear, do they grow? And then that will guide us to determine whether a biopsy is needed and the workup is needed and whether that truly indicated lung cancer. There are a lot of cautious about exposing people to unnecessary procedures. So false positive rate, it was a problem raised by the trials, but in reality practice, we're more cautious than that, and that is really low. And because of the data I've shown you about survival benefit, it's in the guidelines, so all the insurance covers lung cancer screening. Oh, this is just the summary of the guidelines. This is by U.S. Preventive Services Task Force. There are some changes along the years based on the clinical trial data prior to 2011. I think they had different age cutoff. They had different kind of cutoff for pack year smoking history as well. But this is the most updated one based on all the trial data combined together. Age starting 50, was 20 pack smoking history, or have quitted within past 15 years. And recommendation is to do low dose CT scan every year. Okay, I think that's about lung cancer screening per se, and just want to touch a little bit on the smoking part because that just ties so closely with lung cancer. It is the primary cause of lung cancer. As a matter of fact, 85% or 83% of lung cancer are related to smoking history. If it's, you know, you're smoking as a time of cancer diagnosis, or within the 15 years you were smoking. And secondhand smoking is also related to lung cancer diagnosis, but much less, about 3%. And then there are environmental or occupational exposures, as I mentioned before, asbestos, and then radon, and others such as air pollution. Especially children and non-smoking partners are vulnerable if smoking was around them. This is some examples of occupational environmental risks. Okay, so what does smoking do to one's body? I mean, we're talking about lung cancer, but it's more than just lung cancer that the smoking is relevant to or tied to. It does increase head to toe a lot of, for example, cardiovascular disease, a lot of vascular disease, heart disease, stroke, and of course will cause a lot of lung issues. You will have trouble breathing. We call it COPD, chronic obstructive pulmonary disease. It does related to smoking is found related to over 20 types of cancer. So not just to lung cancer, for example, head and neck cancer, bladder cancer, gastric cancer are all related to smoking as well. So a lot of organ system and a lot of cancer types other than lung are related to smoking. And they're costly too. So some benefit of smoking cessation, there's probably a better slides here. This is a rather very simplified slides, just highlighted a couple organs here. Within days to 2 weeks of stop smoking, your heart rate will come down, your blood pressure will come down, your oxygen saturation, your blood will get better. Longer term, from months to years, your lung will be better, you will breathing better, less coughs, that you will feel like less cough, less shortness of breath, less cardiovascular disease, so heart function improve, and also neuro as well, because smoking is tied to as one of risk factor for stroke as well. And this is probably a more confluent slides. I am just gonna pass probably. Okay, so yes, I mean, people do understand that smoke cessation is important, but they're often so stressed and so worried that they will not be able to achieve that. It is not an easy task, but there are a lot of help you can get. We have a lot of resources to guide you, help with that part. And here is just some simple examples that I would talk to my patient about on the right side of this on this slide. There are patches if you have nicotine addiction problems. There are patches, gums, and hard candies that can help kind of reduce your craving for nicotine. There are medications which such as bupropion, and there are like anti-anxiety medications, but they're really not too much a side effect and help you kind of again stay in the quitting state, like make you more likely to stay in not smoking. So there are medications helps, and of course talk to the therapist if there are available resources. So a lot of support, a lot of help you can find. Just let us know, and we should be able to provide the right resources for you. Oh, here we go. That's one of the quit line here. Okay, in summary. Okay, I'm on time. In summary, what I'm intending to cover is lung cancer screening for high-risk people with for people with high risk for lung cancer. Lung screening with low-dose CT is a life-saving tool because it leads to early detection of lung cancer, and because early detection of lung cancer or early stage lung cancer has a better survival rate compared to late stage lung cancer. And if we screen enough people and save people's life and or prolong their longevity, it improves public health outcomes. And I want to highlight that smoking is number one cause of lung cancer, and smoking cessation should be discussed and taken actions, and we have more helps if we needed to. That's it. Thank you so much for listening, and any questions?
Wonderful. Thanks so much, Dr. Wang. Let's go ahead and save the Q&A for the very end.
Thank you. Well, good afternoon, everyone, and thank you so much for joining us today. My name is Dr. Ismail. I'm a pulmonary critical care and interventional pulmonologist. And what that means is I specializes in minimally invasive procedures for diagnosis and management of lung cancer. I'm currently the director of the Lung Nodule Center at CPMC, Sutter CPMC. I did my training, my residency in the Midwest in St. Louis, and then carried on for my fellowship at UC. I finished my pulmonary and critical care fellowship, and then I went on for the interventional pulmonology training for 1 year in Heidelberg in Germany. Since then, I've been a faculty at UC, and I joined Sutter CPMC about 6 or 7 years ago. This is just a quick summary of who I am. And again, thank you for joining us today for our talk about lung cancer screening. So Dr. Wang had highlighted a lot of very interesting points. I'll try not to repeat any of these points. And I will definitely address the issue with the increasing incidence of lung cancer in women, specifically in Asian women. So as we highlighted, November is Lung Cancer Awareness Month, and we try to carry several community events, sometimes even screening events, to just raise education for lung cancer and how can we be screened for lung cancer as well. I'm going to start a little bit basic by what is lung cancer. And I get this question a lot from my patients. Is like, can you explain to us what is lung cancer and how it happens? And basically, it's a growth. It's a malignant growth. It starts from your lung tissue and sometimes starts from the air pipe. It's uncontrolled cell growth and replication, which becomes which can spread to different areas in your lung, in your air pipes, and then metastasize to different parts of your body if left untreated, undiagnosed, and untreated. There are two major types of lung cancer. There is a small cell lung cancer, and this is basically mostly common in smoker patients. And there is a non-small cell lung cancer, which we see a big percentage of this in smoker patients, but now we're seeing more and more of that type in non-smoker patients as well, men or women at different age groups. Most types of lung cancer, or 80, 95, 90%, are the non-small cell lung cancer. As Dr. Wang has highlighted, when you look at the incidence of lung cancer among men and women, it's the second cause of lung cancer. So it comes after breast in women, and it comes after prostate in men. But when you take a look at the overall cancer death cause, meaning is like what's the number one cancer killer in both men and women, you will see that lung cancer is the number one cancer related death in both men and women, which is actually scary. And it has been there for a few years, and unfortunately we have been making significant progress or improvement in this mortality data when it comes to lung cancer death. So when, again, I don't want to repeat what Dr. Wang has said, but this just slide tells you that basically give you some statistics about that more than 200,000 new cases of lung cancer diagnosed in 2009, and we're pretty much still on that number. To simplify it, we have every 2.5 minutes, there is someone in the US who gets diagnosed with lung cancer. why is it important to detect lung cancer early? And again, I'd like to say that again, and I would always say this to my patients: important to detect lung cancer early, because the 5-year survival significantly increase when we find out lung cancer at stage 1 versus when we find it at stage 4. Meaning is, if I diagnose my patient at stage 1 lung cancer, we can take it out, patient will be cured of cancer, and their five-year survival is high. While if we detect lung cancer at late stages, at stage 4, where it has metastasized to different organs outside of the lung, then at that time our options for treatments are limited and surgery is no longer an option. And that's when we see the mortality rates gets very high. So based on this slide, it's really important for us to detect lung cancer. Our reality shows that overall, if we combine all stages of lung cancer together, that the survival rate is about 19%. And unfortunately, it has been 19% for quite some time. So even though we're talking about lung cancer screening, even the guidelines has changed for lung cancer screening, even the insurance companies cover for lung cancer screening, yet still the mortality is very high. And the reason behind this is we're not able to detect the lung cancer at early stages. So what are the risk factors of lung cancer? And of course, smoking remains the #1 risk factor for lung cancer. And we know this, and Dr. Wang has highlighted this very nicely, that yes, we're seeing incidence of lung cancer in non-smoker, but yet the majority of lung cancer patients are smoker or ex-smokers. There is other risk factors as well, which we call controllable risk factors, meaning is exposure to certain environmental factors that can increase our risk of lung cancer, including radon, asbestos, and toxic workplace chemical that I will talk about. And then unfortunately, there is other risk factor that we can't control. It's out of our hand, meaning is genetics. If we have family history and you have certain gene risk, or genetic mutation that's associated with lung cancer, that would increase the patient chances of having lung cancer. Air pollution is everywhere right now. So even though maybe in our direct environment, we're watching everything, but we're going to go walk out in the street, we're going to fly, we're going to go to other countries, and there is air pollution, as we all know. Other thing is radiation therapy. If a patient gets diagnosed with breast cancer or prostate cancer or lymphoma, and they had to go through radiation therapy, this radiation therapy by itself can no of lung cancer. All right. So as we talked, smoking remain the #1 risk factor for lung cancer. And it's the leading risk factor for incidence of lung cancer. And 80% of lung cancer deaths are thought to result from smoking. We always remind the patient that it's never too late to quit smoking. I know we have been seeing a decline in the number of patients who are currently smoking, and this is great because we have a lot of smoking cessation programs, a lot of new medication that can help, yet there's a good percentage of patients still continue to smoke. This is just again to highlight what Dr. Wang said is the relative risk of lung cancer in long-term smoker compared to non-smokers, about 10 to 30% increase, which is pretty significant. Same thing applied to secondhand smoking. So some of us had lived with our parents and grandparents, and during these days they used to smoke inside the house, and you would get exposed to that smoking, so that put you at a risk as well for lung cancer. Hookah smoking now, which is very common among the young population, and it's the new cool thing for smoking. Again, some studies have showed as well that hookah will contain the same carcinogens or the cancer-causing substance as cigarette that can lead to increased incidence of lung cancer. So what is radon? And I get this this question from patients. They're like, oh, we haven't been smoking, but we hear about radon. What's radon exposure? What's arsenic? Where do we find this? How we can test for it? So radon is a naturally occurring radioactive gas. and it results from breakdown in the uranium in the soil and the rocks. So it's not like something we can control or we can avoid, and it's not something that we can see, taste, or smell. And according to the US Environmental Protection Agency, it's the second leading cause of lung cancer, and it's the leading cause among non-smoker as well. Now, you can get your house or your home tested for radon, and you can detect the percentage, like how much exposure are there. And there's certain measures that you can do. But again, as I said, most of the time, it just comes from the breakdown of the uranium in the soil or in the rocks. Arsenic as well, it can be present in high level in some drinking water, and that can increase the risk of lung cancer, especially if the patients are already a chronic tobacco use or chronic smokers. Other cancer causing agents in the workplace, radioactive substance such as uranium, but I think we're doing a good job nowadays with trying to monitoring for these radioactive substances. Other inhaled chemical or minerals like silica, coal products, mustard gas, and we always take very detailed history from patients, because as I said, a good percentage of our patients, they've never been a smoker, yet they still have lung cancer, and we will find a good percentage of them, about 20% or even more, that they've been exposed to these environmental factors. Now, how about patients who have COPD? And we get these questions very often because we are pulmonologists or lung doctors, and we have a lot of patients who have COPD from smoking. Well, if you had been smoker and you have COPD, then definitely your risk of lung cancer is higher than a patient who's non-smoker or doesn't have COPD. Patients who have pulmonary fibrosis or scarring of their lungs, even though for unclear etiology, they're still at a higher risk for developing lung cancer. Patients who carries an alpha-1 antitrypsin genetic mutation, they are still at a higher risk of lung cancer as well, and they tend to present with chronic obstructive pulmonary disease or COPD kind of picture, even though they haven't been smokers. As I said before, radiation to the chest area for women, it's most commonly for the breast. And we see a lot of women who unfortunately had a breast cancer, was treated, and now they present with lung cancer. Or patients who have Hodgkin lymphoma and they got, again, radiation to their chest, that definitely increased the risk of having lung cancer. Having a history of lung cancer yourself or anybody in the close family member, usually first degree relative of lung cancer, they have an increased risk of developing lung cancer. And this, I think we have been seeing more and more of this when it comes to increasing incidence of lung cancer in non-smoker women particularly. And that increased risk would persist even after you adjust to the age and the gender and the smoking status. All right. I get this question a lot from the patients, like, are there certain types of food that cause lung cancer? And unfortunately, I wish I have a very straightforward answer for this. And I wish there'd been trials that looked at that. Unfortunately, the number of trials looking at food and lung cancer is pretty limited, but there is some sporadic data that talks about, having these French fries, fried food, basically all these kind of food that have some preservatives can increase the risk of lung cancer. And I can say that this is other type of food that's anti-cancer food, but these food at least have not been associated with lung cancer, which is like the leafy vegetables, the turmeric, for example, which a lot of my patients take it right now, believing that actually it can prevent lung cancer. But these are all like based in very small sporadic trials. Unfortunately, there is a not big trial that looked at risk factors of lung cancer when it comes to our food intake. This is just some studies as well that came from Japan, looking at something called the beta-carotene supplements that a lot of patients take right now, but they found that it does increase the incidence of lung cancer, especially in smokers. So that went away. MD Anderson looked at the diet with high glycemic index, meaning is food that increase your blood sugar very quickly in a very short time. and looked at the correlation between that type of food and incidence of lung cancer. And they found actually there is a correlation there. So there, I think it's good in, whether or not even it's correlated to lung cancers, to stay away from food that can raise your glycemic index or raise your blood sugar very quickly in a very short period of time. There are studies that came from China that shows that high fish consumption decreased the risk of lung cancer among never smoker or non-smoker patients in China, which again, is very small trials. Now, looking at the genetic factors, there is a common gene, which we call the epidermal growth factor gene, a receptor gene mutation, and this is very common in women, non-smoker, and I will talk about this a little bit in details. And there is other mutations as well that we always check any patients when they have lung cancer. We always check them for these genes mutation, and we're going to talk about this shortly after. So as Dr. Wang said, when patients start having symptoms and signs because of their lung cancer, it's usually too late. Lung cancer is one of these very tricky cancers. They hide in your lungs. They don't cause symptoms. They grow. And by the time they start causing symptoms like coughing, shortness of breath, chest pain, coughing up blood, it's usually pretty late. When the patient, when they start having back pain or jaundice, that means that the tumor has gone to different parts of your body. So this is an example of one tumor. This is the inside the lungs, how it looks inside the lungs. You can see the air pipe right there. And then the other air pipe, you have this white tumor growing on there. Same here. You can see that tumor growing inside the air pipe, your breathing pipe. And by that time, that's when the patients start having symptoms. That's when the patients start having coughing. That's when they start having coughing blood. That's when they say, oh, we're getting more short of breath. So you can see is by the time they present with symptoms or the patient present with symptoms, it's usually pretty late. So we're dealing with a tough situation here. We're dealing with a cancer that is common, that there is a lot of risk factors other than smoking to have this cancer. Their environmental exposure is very high risk, and unfortunately, we cannot control this. Yet, it's very tricky, it's sneaky. It doesn't show up until it's very late stage. And by that time, the mortality is very high. And the options for treatment is limited. So it's a very tough equation here. I mean, how can we find this cancer early, and how can we detect it early, even though the patients are, asymptomatic, or even they don't have that obvious risk factor, or even, we have this risk factor that we cannot control. This is just to show how we stage the lung cancer. So this is stage 1, it's only in the lung. Stage 2, it stays in the lung and the lymph nodes around the lung. Stage 3, it starts invading into another lobe on the same side of the lung and into the lymph nodes in your chest. And then stage 4, when it goes to the other lung and it goes to other organs, including the brain, the bone, the liver, and that's what we call stage 4. And stage 3 and 4 are very advanced stages of lung cancer where we have limited options. A quick review. So after the trials that Dr. Wang said, we have 2 major trials. After these 2 major trials that proven that, oh, if we screen for lung cancer and we find lung cancer early, then the mortality gets much better. And we actually are able to save patients and improve their survival. The new guideline came up and they actually narrowed or brought down their age for screening. So before it was like 55 to 80, now it's 50 years old to 80 years old, which is great. And instead of having these patients who qualifies have higher number of smoking, they lowered it down. So they say, okay, if you smoke 20 pack per year, and I'll show you an example what that means. And if you're still smoking or smoked or stopped within the last 15 years, then you should get a CAT scan every year to make sure you don't have lung cancer. So finally, we have some sort of guidelines that can help us screen patients for lung cancer. And this is just a summary of what I just said, and this is how you calculate. So if you smoke 1 pack per day for 20 years, then we call that a 20 pack year. So you would qualify. And if you smoke 2 pack per day for 10 years, that's still 20 pack per year, which you still qualify for. But I advise every patient who's smoking is just you need to go and talk to your doctor and ask for lung cancer screening, because even though you quit and even though you weren't smoking much, you still could qualify for lung cancer screening. So how do we do the lung cancer screening? So we do it through a CAT scan, and you can see here, this is the scanner, and it's like a big open donuts, as you can tell. And you see, we see different types of nodules, like, and all of these 3 are cancerous, but you can see how they look differently. Like this is like, seems like a little fuzzy thing. This comes more like solid and defined. And this is here more solid growth. I always tell the patients, is the cancer, imagine like a pimple in your face. You have the same thing. It's like a pimple in your lung, except that that pimple is cancerous. And a lot of patient comes back to me and is like, okay, well, if I'm getting a CAT scan every year, would the radiation from the CAT scan by itself increase my risk of having cancer, including lung cancer or other type of cancer? Like for women, for specifically, they're like, oh, are we now at a higher risk of having breast cancer? So this is just to compare the low dose CAT scan. So the scan that we use for lung cancer is called the low dose CAT scan. And the amount of radiation we get from this is very low. Okay, it's almost comparable to 6 months of natural background radiation. So the amount of radiation is definitely lower than a regular CAT scan. It is higher than a chest X-ray, but we know that chest X-ray is not a good test for screening. It doesn't show these small nodules. And the full dose CAT scan, it gives us a lot of radiation. So that's why we came with the low dose CAT scan, which gives us a small amount of radiation just to detect these nodules without increasing the risk of other cancers. When we find these nodules in the old days, when we used to find these nodules that I showed, we didn't have any way to biopsy these nodules. So we would think, okay, you have a growth in your lung. That growth is very minimal. It's like 1 centimeter. We are going just to leave it and watch it. And next time the patient comes, it has gone everywhere. So thankfully, we have a new technology, thankfully. And we have it here at CPMC. It's the robotic bronchoscopy. And basically that robot, which we are in control of, it allows us to navigate to these very small lesions that you can barely see even in the CAT scan, and able to take a biopsy of these lesions and confirm if it's cancer or not. So instead of the old days, it's just leaving these patients and them, oh, come in another 6 months. Maybe it would be big enough for us to be able to biopsy that. Now we're able even to biopsy these nodules that are less than 1 centimeter, and we think it's cancerous. And once we prove it is cancer, then it gets easier for us to take it out. Patient gets cured because it's an early stage, and they be cancer-free. We also carry this as well here at CPMC, and I think it should become the standard of care, is when we have a patient, for example, who have abnormal lung nodule and we think it's cancer, but it's very small. So we go in with the robot, we diagnose it, but while the patient is under general anesthesia, we put a little mark under, like little blue dye on that pimple or that nodule on the lung. And while the patient is under general anesthesia, at the same surgery, the surgeon would come up and basically take that nodule out or that cancer out. So that way the patient got the diagnosis of his cancer and removed it within like 3 or 4 hours surgery. And they go home after 2 or 3 days home free. So this is the assisted single anesthetic procedure that we carry here as well at CPMC, and it was as well. A lot of our patients prefer that to be treated that way, especially if we have high suspicion of lung cancer. They're like, well, you know what? If you diagnose it and it's cancer with the robot, to just go ahead and remove it right away. So that basically eliminate weeks and weeks of waiting for the patients for more testing and biopsies and prep for the surgery. So moving on to another topic in relation to lung cancer screening, and this is very important, is women versus men. So, in the old days, or still even until these days, when we think about lung cancer, everybody think about that 80 years old guy who's chain smoker, who used to be in that Marlboro cigarette box, and we're like, this is the patient that gets lung cancer. Unfortunately, not. Actually, women now, younger women, non-smoker women, younger men, non-smoker men, everybody can get lung cancer. And I just showed you why, because you cannot control the environmental exposure, you cannot control the air pollution. There's a lot of risk factor, genetics, there's a lot of risk factor that we cannot control. And interesting enough, when we look at the women that comes to our cancer screening program, that are referred by their primary care doctor, they're only very small percentage, 22%. But women who read about lung cancer screening and they realize, oh, we might qualify, and they refer themselves to the program, it's 56%. So it tells you that even some physicians and some primary care outside there still believe that, lung cancer cannot affect women, which is completely wrong, because actually lung cancer has become the disease or the cancer for women. And it's the number one cause of cancer death in women, in addition to men. So we need to educate people, we need to educate physicians, we need to educate our community, we need to educate our patients that lung cancer is a cancer for women, same as it's a cancer of men. There is different foundation that looked at lung cancer in women as well. We have the Go-To Lung Cancer Foundation that specifically talks about women and lung cancer risk. And the way I simplify it for patients is a lung cancer kills about 198 women, now 198 women every day. So we have one death, one female, one woman die from cancer every 7 minutes. So 8 patients per hour. So that's a significant amount of patients. 198, that's a Boeing plane. So imagine like you're losing 198 women every day from cancer death. So if you talk about the statistics, and I don't want to, sound boring with all these numbers. I know it's a lot of numbers, but it kills 1.5, lung cancer kills 1.5 times as many women as breast cancer. So we had made significant improvement in breast cancer. We're able with mammography to detect breast cancer early, to treat it, to improve survival, yet we're not making any improvement with lung cancer. 1 in 17 women will develop lung cancer over their lifetime. And even though because of the decreasing the smoking rate among people, especially the young people, we've seen lung cancer diagnoses have been kind of leveling off or maybe slightly declining, but it's not doing the same for women. It's doing this at a slower pace for women than for men. And still smoking represents the number one reason why women have lung cancer, but 20% still of women diagnosed with lung cancer are never smoker. So meaning is 1 in 12 men with lung cancer have never smoked, in contrast to 20% of women are non-smoker. So it's still a high percentage of women diagnosed with lung cancer are non-smoker. And non-smoker who develop lung cancer are nearly twice as likely to be women than men. So why are we seeing that shift? What's happening? Why are more women now showing up with lung cancer? And why are these women are never smoker and still showing up with lung cancer? So as I said, smoking is still one of the major factors, and data showed that if you have a man and the woman, they are the same age, and they start smoking from the same age. Let's say they start smoking at 20 and they smoked until the age of 60. And the woman smoked 1 pack a day, and the man smoked 1 pack a day, and they exactly the same number of cigarettes. Yet the women are at a higher risk of developing the lung cancer than the men. Why? People believe it could be related to hormonal factors. People could be believed related to maybe viral infection, genetics. We don't know. But it's different in women. Women are more susceptible to develop lung cancer. And if you measure this, you can say, okay, well, if I have an environmental exposure and we have air pollution everywhere, then probably women are more at risk of developing lung cancer than men, if we go by the same theory. Again, for non-smoker, if you look at that in the 21st century, the incidence of lung cancer among non-smoker is rising. And as I said, 2.5 times more likely to happen in women than in men. And on top of this is 1.5 to 2 times higher in Asian women. So not only we identified that women at a higher risk, we identified that Asian women, on top of that, are a higher risk of developing lung cancer. All right. So what's that could be before? Sorry, the lights went off. What risk factors could be? We talked about outdoor, indoor air pollution. We talked about secondhand smoking, radon, asbestos. We talked about how women are, they based on their genetic composition, they process these toxins in a different way, and hence they are at a higher risk of developing lung cancer, even though they're being exposed to the same factors as the male partner. So why is Asian? Why is it not Asian? Well, I think we nailed that down to genetic factor. There's certain genes that we find it common in certain population than other, and maybe having these genes and exposed to the environmental exposure triggers the lung cancer incidence in these women. Some of these genes I mentioned, like the EGFR and the KRAS mutation, you can see that the frequency of these genes in women are higher than the frequency in men. So, okay, so women are higher risk of having this gene, and then you get exposed to environmental factors that trigger these genes. Maybe there is some hormonal elements to it, maybe it's some metabolic elements to it. You combine all these factors together, and then boom, you have the lung cancer. And the last meeting, one of the big meetings for oncologists in 2022 did actually come with this theory. And they said, yeah, there's actually a certain pollution in the air called PM 2.5. That's what they called it. They say if a woman who carries this mutation, the EGFR mutation, gets exposed to that particle in the air, that actually promote them to have lung cancer. All right, so great. So we're able to, narrow it down to this, but can we avoid exposure to this PM 2.5? Can we avoid exposure to environmental factors? Can we modify this gene? Unfortunately, we can't. There is more and more awareness is coming to this. There is more and more awareness talking about women and lung cancer. And there is a lot of people advocating that women, especially Asian women, should have their own guidelines for screening for lung cancer. And what I tell my patients, I say, even if you don't qualify by Medicare criteria.
Your attention, please. This is a test of the backup overhead page system. This is a test of the backup overhead page system.
So even though these patient population or women do not qualify based on the Medicare criteria, they're not between the age of 50 and 80, they haven't been smoked, they haven't smoked or never smoker, or smoked but quit 30, 40 years ago. But if they do have a family history, if they had a history of breast cancer, if they had radiation, if they got exposed secondhand smoking, we need to have a separate guidelines for these women. And we advise them that if they develop any symptoms, that they should immediately seek medical advice. There is the Female Asian Never Smoker Registry, which looks at specifically Asian Americans diagnosed with lung cancer who has never smoked. And this is a multi-center registry, and we're waiting for the data to be published from them, and hopefully there will be changing in some guidelines. The Women and Lung Cancer Research and Preventative Service Act of 2023 kind of highlighted as well the increasing incidence of lung cancer in women. So all of these organizations are trying to raise awareness for lung cancer in young patients, in young women who are never smokers. We do currently have a women lung cancer HEAP program at CPMC. It's within our lung cancer screening program. This program is we're still building different aspects, but we're trying to do is we're trying to focus on the gender medicine in a comprehensive way. We're trying to specifically look at women and their risk of lung cancer and basically targeting screening and treatment to this population, looking at their risk factor, looking at their environmental exposure, looking at gender-specific lung cancer discoveries, and bringing new therapies for these women. We are targeting more women through the Breast Health Center. So we are launched this month in honor of the Lung Cancer Awareness Month. We're launching the GLAM program, which basically we're asking women who are going for mammography to fill a questionnaire. And if they do qualify for lung cancer screening, we will screen them. We'll offer a low-dose CAT scan for them. If they don't qualify, but yet they still have risk factors for lung cancer, family history, other cancers, previous radiation, strong environmental exposure, we would still provide counseling and offering them low-dose CAT scan as well for lung cancer screening if needed. With that, I'm going to end by saying that smoking, it's still #1 cause of lung cancer. And this is just a famous say for Mark Twain. Please spread the word for lung cancer screening. Lung cancer could save lives. We've been featured in media with our program and robotic bronchoscopy. So please make sure you visit this as well and learn more about lung cancer. And with that, I will stop. Thank you.
Wonderful. Thank you so much, Dr. Ismail. Yeah, we can now open it up for questions for our Q&A segment for the remainder of the time. I know we had a few questions in the chat, and thanks so much, Deborah, for typing in some answers there. Yeah, your presentation, Dr. Ismail, kind of answered a lot of the pre-submitted questions, lots about Asian American women and their risk for lung cancer. So thank you so much for talking about that. I think that was really
so let me grab one of these questions. Is that okay?
Yeah, please do.
So I have a question here from Lisa. Lisa said, my mom had non-small cell lung cancer and found out accidentally. My insurance would not pay for a preventive CT, would not pay for me to have a CT screening. Neither of us had never been smoker. I have 2 friends that died in their 40s from non-small cell, both discovered stage 4. And unfortunately, and my mom found out stage 1 accidentally. My insurance with Sutter refused to pay for a baseline screening. Okay, all right. So I'm going to answer to Lisa. So Lisa, as you can tell from the, and I believe Deborah might have answered that, but as probably what Deborah said, there is no specific criteria now for women who are younger than 50 years old who are not smokers. So that's why you're going to have this fight back from the insurance. Yet, the way to go around this is to say, okay, we can always say, okay, we will try to do a low dose and fight back with the insurance and saying you are a high risk because you have a strong family history. If you do have any symptoms, if you're having coughing or weight loss, we don't know why, that would qualify as for you as well, or enrolling with something with the GLAM, with the research study or the registry, which we say, okay, you're at a high risk, and we should be offering you low-dose CT scan. So all of these are options for you to do this. CPMC does offer a private pay option with a reduced cost as well. So that would be another option. But definitely, I hear your anxiety, and it is, you have risk factors. I agree with you. Unfortunately, our guidelines haven't reached this yet, but we're hoping that we can help with that. So Deborah, I'm sorry if we haven't introduced Deborah. Deborah Bishop is our great nurse navigator for the lung cancer program. She is behind all this amazing work that we have been doing, and she's been doing a great work talking to the patients, screening them, getting them their CAT scan. She is definitely to go person in order to get your screening completed. Any other issues you would like to address, especially when it comes to women and lung cancer, Deborah?
Nice to meet you all. Sorry, I'm having trouble with my connection. I just wanted to touch on those of you that want to have an exam but don't meet the requirements. So your other option is to speak to your doctor. If you have symptoms such as weight loss or reasons for screening, they can order it as a diagnostic CT and use the low-dose protocol. It's essentially the same exam. The difference for you would be when it's ordered as preventative, there's no shared cost. So if I come in to Dr. Ismail and I've lost 20 pounds in a month, I've coughing up bloody sputum, she can go in and order a diagnostic CT, and I may have a copay. So I may have to pay $20 or meet my deductible. That's the difference for it. It's essentially the same exam. So please, if you are concerned and know that you don't meet the requirements, talk to your provider about a diagnostic CT using the lower dose of radiation.
Great. Amazing. Thanks, Deborah.
Yeah, thank you. That's great advice. We do have a question here about what the name of the organization is that does the studies to potentially get a CT.
You can, Lisa, you can call our lung cancer screening line, and we can direct you to which route. I mean, if you'd like to fill that questionnaire with the GLAM, with the group lung cancer mammography, we can definitely send it to you as well. As I said, we just launching this program and during November. And we can definitely help you as well. And if you meet a lot of the risk factors, as I said, we can always look at different options to get you the scan. Deborah, do you have a different answer? I don't know if I'm answering this question right. Can you share a link? Yeah.
Can you share it? Lisa, I don't know that there's an actual study that's going on right now in San Francisco that's going to offer you a free CT. But as I said, we've got some kind of workarounds. And if you would like to do the questionnaire from our GLAM program, I'm happy to send that to you so we can see what your risk factors are.
Great.
While we wait for any more live questions, I do have a couple of sort of advanced submitted questions. The first one, and both presenters talked a lot about this, but maybe we can do a quick review. What does lifestyle have to do with preventing lung cancer? Do you have like a few quick bullet points we can cover?
Sure. Lynn, do you want to take this or you want me to take it?
Either is fine.
Go ahead.
Yeah, I guess the first thing that come to my mind is the universal cancer risk factors, which are obesity, and so weight control and exercise. Those are two universal cancer kind of preventative tools. Applies to all cancer types, major cancer types. Food-wise, I think Dr. Ismail, you already touched the base that there's really no study pinpoint which type at this point, but high hyperglycemic index score foods are related to, again, obesity. So from that angle.
Right. So yeah, I agree. I mean, definitely smoking, that's number one. And then looking at your food, and this is just for all cancer types. Processed food that has a lot of preservatives are not good. Food that high glycemic index. If you live in an old house or an environment where you think there might be some environmental exposure, some radon exposure, maybe you can go ahead and test it and ask to be analyzed. This is one thing. yeah, I think that pretty much stay away from people who smoke too.
Great. Thank you so much for the review. Yeah, the rest of our sort of previously submitted questions were covered. Lots of questions about Asian American women and their lung cancer risk. We did have a question, and this was also covered, but can we talk a little bit about how secondhand smoke, either from cannabis or tobacco or any other sort of sources, can increase your risk?
So we talked about hookah, and we said hookah carries the same risk for lung cancer, same as smoking. Smoking cannabis and vaping. So vaping is different because vaping is something new. We know that vaping is associated with other lung disease. So it can cause significant lung inflammation, or what we call ARDS, or interstitial lung disease, and these can increase your risk of lung cancer. The data on this is not very strong yet because vaping hasn't been in the market for a long time, but we see cases where they have significant inflammation and damage of their lungs. Now, over the long term, like 5-10 years from now, are we going to come back and see increased incidence of lung cancer? We might, because clearly it does cause some damage with your lung tissue. Smoking marijuana, we don't recommend it. We again, we believe it still it can increase your risk and for lung cancer, and might carry some of the carcinogens that associate with lung cancer. So we don't recommend it as well.
And if I can just interject, when it comes to the screening criteria, the active smoker or quit within the last 15 years, I had a gentleman ask me about that. They are working to get the quit within 15 years limit removed. But until that happens, this criteria is for cigarette smoking only. I have a lot of patients that will say, well, I quit smoking 15 years ago, but I still vape. They don't count vaping or marijuana. It's strictly cigarettes. So that's why I'm saying, if you're very concerned, reach out. We can have a discussion and maybe do a little bit of a workaround so that you can get the imaging that you need.
Great. Thanks so much for that clarification. It's definitely important to talk about vaping as it's so much more prevalent these days. Yeah.
It's a whole different talk when it comes to vaping and lung disease, unfortunately. We don't know a lot about it, so.
Yeah, it's still so new, I can imagine. Yeah, that's all of my registration questions. If anybody else here in the audience has more questions, definitely put them in the chat or the Q&A box, or feel free to raise your hand and I'm happy to help you ask it verbally.
Great. I think this will be recorded. I want to thank everybody who attended today. Thank you. Thank you for participating and listening. Please spread the word for lung cancer screening. Please remember, it's not a disease of all men. It's can affect men and women. It's actually, lung cancer is the disease of women now. Spread the word. Make sure that if you have symptoms, to seek help and medical advice. Thank you.
Dr. Ismail, one more question. Lisa wants to know if there are symptoms that show up in stage 1.
So unfortunately, no. As I said, by the time symptoms showed up, it's usually late stages. So stage 1, unless it's found incidentally, like as you mentioned, some of your friends were found this incidentally, meaning is they had cold and their physician thought they might have pneumonia. So they went and did a CAT scan, and incidentally, they found this nodule that looked suspicious. But if stage 1, it doesn't cause symptoms.
Great, thank you. Right, well, I think that sort of wraps it up. If anybody has questions, definitely feel free to email them to me. My email is on all of the invitations, and I will get them to the right people to answer your questions. Once again, I just wanted to thank everyone for joining this presentation hosted by Sutter Health CPMC Cancer Services and Community Health Resource Center. Thank you to Dr. Ismail, Dr. Lynn, and Deborah for all taking the time out of your very busy schedules, especially during Lung Cancer Awareness Month, to present on such an important topic. Everybody, please keep an eye out for a post-event email with a link to the recording. Feel free to share it with your friends, and keep an eye out for more emails for upcoming events. I hope everyone has a great evening, and thank you again for joining us tonight.
Thank you so
Thank
much.
you all.
Thank you,
And thank you,
everyone.
Lily.
Thanks. Take care.
Bye-bye.